So this is the exciting part. I am really excited to have Dr. Knight here presenting with us, and I'm just going to do a very quick overview of or introduction of Dr. Knight, who is a professor in the Division of Epidemiology within the Department of Internal Medicine at the University of Utah. And she is a social and behavioral scientist who's trained in clinical psychology and health services. And her focus has really been on understanding patient values and preferences in diagnostics and treatment in a variety of health outcomes. And she has been funded by PCORI and is just really interested in the community engagement and decision making within a patient's rights and values, preferences, as I just stated. And so she has experiences designing innovative approaches to community engagement and community, both in terms of patients and health systems, and to really move community patient perspectives into policy and practice. And so much like the rest of us, she's really focused on improving health outcomes. And she's studied determinants of health and health disparities. So without any more hesitation, Dr. Knight, I invite you to take over.
Thank you so much, Julie, and thank you for that very lovely introduction. So I'm really excited to be here today and also tell you about one of my favorite places to work, and that's in the area of engagement. And I'm going to share with you a type of engagement that I found to be incredibly useful in a number of ways that we'll talk about. And I'm going to proceed with this in somewhat of an interactive workshop approach, where I may ask you to respond in the chat to questions I might ask. And so to get that started, I am wondering if you could leave a message in the chat saying if you have experience using deliberative democracy engagement or deliberative engagement. Next slide, please. And while we're waiting for the messages, why don't we move on to our first content slide? Sara, are you able to move the slides forward?
Yes, are they not moving anymore?
No.
Okay, let me.
Okay. Thank you so much, Sara, for fixing that. And so I see that many people have no experience. I'm glad, Erica, you said no experience that you know of, because you may have been in some of these groups in the past. So that's a great place to be. And some of you may recognize the description of these groups as we go through this presentation. So this is sometimes known as democratic deliberation. And the democratic deliberation history goes way back. And the Greek philosophers used it actually originally, and with the idea that in a democratic society, we often want to bring together groups of people who are in the society in convenings where they would deliberate over a particular issue that affected the society. So issues of societal importance were of interest, and they actually ran these groups where they were searching for the best argument or the best policy to use. And so the deliberation was a back and forth kind of deliberation between members of the public. And so it is a discussion, and even going back to its Greek roots, that seeks collective solutions to shared challenges that are value-laden and often involve normative trade-offs, such as vaccine mandates or shelter in place. So there's some trade-off in the public view of these policies. And so we often will use democratic deliberation to understand these issues and what the community would like. And so it engages ordinary citizens with diverse perspectives. And that's one of the things that's incredibly important. And I realize people are hesitating to use the word diverse, but this is important here because we really want diverse perspectives to be presented in order to come up with reasoned, respectful discussion about these important social issues. We just don't want necessarily one point of view, right? When we have an issue of societal importance, we want different perspectives. And then we want the deliberators to develop proposals for leaders that are well-informed and that all people that potentially could deliberate would view as legitimate. And so this goes back to its early roots, this democratic deliberation. Next slide.
Did it change slides or is it stuck again?
Not yet. Okay, if you could go back one. Okay, great, thank you. It is an area that has been, in the current time, adopted by people in bioethics. And in bioethics, they've brought out the principles of deliberation in this way, that if we want informed, engaged patients, communities, and other partners, and we want our partners to contribute to relevant, fair, and sustainable decisions about communities, we need to have some principles. And these are some that a colleague of mine, Erica Blacksher, who I'll repeatedly refer to in this presentation, she is an ethicist who has worked in this area extensively, and in particular works with tribal communities. And so these principles have informed her work, and as well as mine, in terms of leading these groups. So we want to establish inclusiveness, fairness, informed goals, and reasoning in producing our recommendations. And so we do want inclusiveness because we do want to hear from all involved as much as possible. We want it to be public-spirited and focused on community values. At the same time, we want our decision-making to be transparent. We want to be ourselves accountable, and we want to be trustworthy. And so some of my work has involved designing groups that would increase trustworthiness, not only of the deliberative process, but also of important community institutions such as health centers, health leaders in communities, and other people who can help community members with health problems. So let's move on to the next slide. These are some of the founding principles. So there are these assumptions with these principles. And we really want to think about the ideas of transparency and accountability as one way of making our work relevant to patients and communities, with others that have an interest in the deliberation who may not be there at the moment that we're having a deliberative group. So we want to think about our transparency and accountability as being extending to the communities and offering something that is trustworthy. We want the policies developed with participation of patients and other key partners. We want them to see these policies as legitimate, trusted, and that gives us the footing to implement, for example, Healthy Families programs. We also want the policymakers and clinical leaders to be more open in incorporating patient preferences and health system designs when they have a role in interpreting the patient voices. So we want clinical leaders to be open to us also to think about patient and community perspectives. And it's difficult for health leaders to do that when they themselves may feel, how can I be accountable for everything in my communities, for example? And so we want to help this process go well for them as well as for communities. We also want to accelerate the translation of results of research that demonstrate that certain health practices are beneficial, for example. And we want to amplify our impact on policy, health professional education, and clinical practice with these groups. And again, we can only do that without thinking about both the patients and then about the health professionals and health leaders in the communities that are going to be implementing these practices. Let's go to the next slide now. So deliberative engagement, as I see it, really progresses toward a collaboration. And it's based on other community-based participatory research endeavors. It includes patient panels that we might assemble to provide an advisory group, community advisory boards that might include more patient advocates and community advocates, deliberative engagements, patient-centered outcomes research, all are part of the same circle of making the perspectives of patients, communities, and other partners, bringing that to the forefront in policy decision-making. Next slide, please. So there was the Agency for Healthcare Quality and Research about 15 years ago now saw deliberative engagement, and particularly the democratic deliberation, that they were starting to see emerging in the early 2000s. They start to see the importance of this, but they thought that one of the barriers to it being adopted was the lack of evidence, especially with communities and the public, and also with vulnerable patients. And so they did a series of studies, basically clinical trials and comparative effectiveness trials. Kristen Carmen published the first one. The first publication is in Social Science and Medicine in 2015. And one of the things that they tested was this particular model of democratic deliberation. And I think it's an important one because it's easy to follow. So the first idea is we're going to convene people. We're going to bring together individuals where their opinions are important in the issue we're trying to inform. And so we need to bring together people with a broad range of experiences that are relevant. And then we want, because they're diverse, when we convene them, we really want to give them an objective overview of the background of the thing that we're going to ask them to deliberate over, the issues and then the different options. And so there's a learning component to this. And then there's going to be, with that, convening diverse perspectives, giving everyone a common ground or floor of education about the issues for deliberation. Then people can interact and exchange reasoned opinions, perspectives, values, knowledge of their communities in this deliberation phase. And so that in order for that interaction to be reasoned and really be able to use all different kinds of perspectives, it also shapes the way we do these groups. So this is an important part. And then we have some conclusion. It might be a consensus conclusion, or it might be a pluralistic, allowing different community perspectives to be heard. And often minority opinions are really important. But we're going to have a report out back to all the deliberants, but also we're going to report out to our funders, the people who gave us the money to do this, and also other community agencies or other policy-making groups. So there's going to be this large dissemination piece. But this is an easy way to think about what it looks like. And next slide. Okay, so I'm going to show you a few pictures, my video clips of a large meeting I did in Birmingham, Alabama. Were very glitchy, so I'm unable to show you them today, but I will show you those in the future if you would like. Seeing it in action makes it a lot more real, and I'd hope to share that today. But I'm going to give you the background without it, but also show you some pictures of some deliberative engagement that I've done. So there is some evidence, as I said, on the feasibility and acceptability and participant satisfaction in engagement. But there is little evidence for acceptability of engaging vulnerable patients and more vulnerable communities, especially when we think about disseminating and implementing phases of research and also where we're going to implement a program. And so that kind of helps us think a little about some of the gaps in the science. But evidence does support deliberative engagement as feasible and acceptable for considering questions of societal importance among members of the general public. And some of the pictures you see here are stakeholders in a large consortium that focused on clinical genome sequencing. And it looked at genome sequencing for parents of newborns who possibly had were observed to have a genetic mutation or change when the babies were in the NICU. And others who were identified in clinics, other adults were identified in clinics and possibly having a cancer-related mutation. And so these are people who we in the consortium, I was one of the leaders who did the convening, but we often share leadership of convenings. And so these are some of the parent participants and patient participants giving their perspectives about involving participants in the research itself as leaders of the research. And so we were deliberating over that, and you can see people presenting their perspectives here. And this was a particularly interesting program because many people saw these parents as being too vulnerable to be involved in any kind of a discussion. It wouldn't work, some people said. But here you see them standing up and talking about their experiences. And some of these members have stayed with our consortium, even though it ended 3 years ago. And so they have continued with a PCORI project I've proposed that will reconvene many of these families together to talk about what they think healthcare systems should do to make this more useful to them as families. And so they have stayed with this, and several of the people in these pictures are actually working with me on that PCORI project. as a legitimate research team members. The next slide, please. And so this idea of engaging vulnerable patients or communities is really an important one. And recent health equity thought leaders suggest that these are the people we should be talking with to understand how the clinical research worked for them or didn't work for them. They are the ones who have the lived experience with barriers. They know the most about how they received help or didn't receive help. And they also have the potential to inform how we can create a smoother system with equity in the dissemination and implementation of translational science work. And so these are the people we should be engaging in these kinds of groups. Still, there are some challenges. Could you go to the next slide, Sala? Oh, good, good. So one of the challenges is that some of the deliberation happens very easily. The group that I mentioned that I did in Birmingham, for example, a deliberative engagement involves interaction between people with different perspectives. And that group, which was mainly community advocates and community health workers who were there supporting, along with me, the facilitation, were able to move quickly from the typical focus group like interaction or listening sessions, which really often don't include any accountability, to they were able to quickly move to an accountable back and forth of issues, privacy versus the importance of research, and quickly had very reasoned interaction. Other groups are slower to be able to do that, and especially people who are not used to that kind of back and forth interaction, not with just with a facilitator, but among themselves. And so we really want to learn more how to create trustworthy collaboration in deliberative engagements. We believe that these trustworthy collaborative deliberations will produce the same thing, but will also start to generate trust in our process, where we can come back to the same people if we have new ideas and want to test them and involve them in the tests, or invite them to be on our research teams. We feel that these collaborations can result in mutually reinforcing relational interactions between vulnerable patients and healthcare leaders. So when you imagine clinic leaders being able to reach community members with these approaches, and you may be already doing it, because I know a lot of people that do this intuitively in building trust in communities. But having a systematic approach for this could really allow you to teach it to many others. And so that's one thing I love doing, is teaching this to others who are going to become the teachers. So deliberative collaboration, it really creates the basis for trustworthiness. And if you've ever met with people in a focus group, you know that they're not necessarily going to tell you everything that's a problem for them, because they're polite, or because they don't know that you're trustworthy yet. And in listening sessions, they don't know if you're going to even do anything, about the concerns that they present to you. And so this is a way where patients can share their lived experience. They can learn to share their lived experience to inform implementation or dissemination of research in community settings. And also, once patients learn that, or community health leaders learn that, like community health workers, they can learn to create these experiences more easily. And so that's what I aim to do in my research during this part of my research life. Next slide, please. So some of the critical choices, I'm going to go through some of this quickly because our time is limited. But these are some of the critical choices in deliberative engagement. Next slide. So one of the things you'll do if you're setting up a deliberative engagement, which I hope that you will start to do, you have to think through how you're going to frame the education and the discussion. So what information, what educational content do you need to create that common ground? What kinds of questions are you going to be asking? And are you aiming, you want everyone to have consensus, or are you aiming for creating different pathways? Those are two very different approaches you might take. And thinking through this in the beginning is this framing. And also, do you want to have small groups? Is it a sensitive topic where you think small groups are better? Or could you have a large town hall meeting on this issue? I actually have had a lot of large town hall meetings in the past when I was doing engagement for the All of Us program in the South and for this large genome sequencing consortium. And so we did have a lot of large town hall meetings. And people, often we created the large town hall to happen over several days. And so you can actually have more than one group or extend a large meeting over several days, or you could have small groups that extend over a few weeks or over a couple months. And do you want, what kind of discussion are you going to have? Are you going to let people iterate? Gee, in the last discussion, we thought about it in this way, but now new things are coming forward. And now we're thinking we are going to change our minds. And a lot of times when you're doing these groups as the facilitator that I'm often in, you have your group telling you these things. Yes, we want to have iterative groups. And they're really participating at that higher level. From that, you can move on and bring people onto advisory boards where they're really, it's not you lecturing people anymore. It's you just really enjoying a wonderful, informed, reasoned conversation where your accountability and your participation in it is important, and where you're going to be able to have these people who you've worked with come back and continue to help you co-create what you're trying to do in your clinic. So recruiting diverse participants, but also don't forget you want people with diverse experiences and perspectives, different styles. And you also want your facilitators to think through what style, what structure of facilitation, and how are you going to report out? Is it going to be vote counts? Is it going to be a qualitative analysis? Are you going to give surveys to collect pre and post deliberation outcomes? So I'm going to move on to some slides I'm going to include that will be part of this presentation, but I won't be able to go through all of this in detail to keep with the time. So framing and informing, what questions are going to frame the deliberation? So these are some slides that I've modified from some that Erica Blacksher uses, and I just made it more aligned with what we're doing here in Utah. But the importance of developing key questions, like a key overall questions. I never develop more than 2 or 3 for even a large group. What are the questions that have significance for participants? So is it, should we have genome sequencing come to our communities? Should we have a large biobank in our community? and where should it be placed? How are we going to recruit people? What are the ways to recruit people so that they are recruited freely without coercion? So there are things like that you think through. And then do we want diverse opinions on this? Are we ready for that? Sometimes diversity can make it harder to come to consensus if you want consensus. Do you want a homogeneous group because these are people who are too vulnerable for a highly diverse and heterogeneous group? So those are critical questions. And then the educational content that you select to inform those questions is also important. Sometimes I've not done slides. I have relied on expert panels to inform us on the issue. That's been very effective. And especially if we can also have a community panel that's community health workers or a community panel that are patients, in addition to all the other panels. And because one of the panels that I've found to be very important is an economics panel. So that looks at cost. And the reason for that is that cost often creates barriers. And if you have a large group that can debate the cost issue, they can often take that issue and put it in proportion to other critical things, like communities not getting support for their health care, or communities not getting a biomarker test that's relatively inexpensive. So these are all things to think through. Next slide. So structures, modalities, and approaches. I mentioned homogeneity before. I mentioned the structure of meetings, but also activities. What kinds of activities are you going to use to identify priorities, importance of issues, relevance of issues to the communities? And I also now include lots of activities that involve collaboration and even co-creation. So if I'm designing a conceptual model for my research, having communities come up with the main concepts they're interested in. What are the things that they want to know about? If you're designing something to build trust, have them think about ways that they've lost trust, or have them think about people who've gained their trust. You know, those are the important kinds of activities to engage with. So next slide, please. So facilitation is very important. It's important also to think about your role as a facilitator. How active do you want to be? Shared facilitation is important in large groups, so you have to coordinate efforts. And you also really want to involve a lot of other people. So I involve people who are going to provide education often. I don't do it myself. I might involve someone who is an educator or someone who's a clinician in that area for the whole group, just to be available to answer questions. I very frequently will involve community health workers, and I can't say that enough because they often have on-the-ground knowledge of barriers and facilitators of many things. And so they also really are very supportive of other facilitators and are able to bring people together. They have that key experience. And then also I've involved videographers to record meetings, scribes to take notes and put notes on the walls so that we can do member checks where people can say, you know, that note up there that we talked about somewhat, yes, we talked about it, but that is really not an important issue. We don't really want to vote on it. And so then people can say immediately, no, take it out. It's not important. It's adding to the list. So all these things are helpful in facilitation. Next slide. And so you really want to create a space that's welcoming, A lot of times the physical space is important, but it's, I think, even more important to offer ground rules and expectations. In the Birmingham meeting that I was going to show you, I mean, I think when I do show this to you, which I hope I get the opportunity to do, you will think, how could this even work? It was a long room where everyone was sitting forward looking at mirrors. And it was a very bizarre space in this hotel, but it was the only space we could get for this meeting. And so actually at one point I asked people, do you want to have breakout groups where we could be in comfortable rooms and sit in a circle? And everyone, I just looked out at the group and I saw a head shaking. No, no, we don't want that. We love this room. We love being so close together. This was great. And there were 80 people in the room. It was relatively small and on a hot day, but they just really enjoyed being able to walk back and forth in this kind of long room and just socialize with people. That was a really important aspect of that group. But you offer ground rules and expectations in the beginning. And also, how do you want to encourage sharing? Do you want to also let some people not share? Or find ways where they can share comfortably. Like during voting, I typically have had social voting. So people could go up to the voting areas and talk amongst themselves about what was important and allow people to change their votes if they like. And then at the end, you do member checks to say, go back over it and say, yeah, we voted on this one. Is that the most important one, or is it less important? And do provide time for clarifying questions in the beginning. And then also follow through with an agenda generally, but be willing, if the group wants to go in a different direction, to go there. In some groups, they don't want to do that. They want to have a lot of control. I find it more helpful in community groups and patient groups to be amazed and simply go with what is suggested and be prepared to do that. So let's move on. I think we're getting close to the end. So there are quality indicators that have been recommended. The DeVries group at the University of Michigan published in Social Science and Medicine some quality indicators. These are they, like equal participation of all participants, respect for the opinions of others, willingness to adopt a societal perspective on the issue, reason, justification. But the Institute of Medicine has recently also developed some quality standards. And next slide. So I thank you for listening to this very rapid review of deliberative engagement and also the kinds of things that I like to see in deliberative engagement. I have about 10 years of experience doing these types of engagements. And I always love doing them, and I'm excited about doing them here in the Mountain West, and also working with you. So this is something that I would offer, Julie, in the future, is more coaching and mentoring on facilitation and consultation on design of deliberative groups that our members would like to use. And this slide is just an extra one if we have more time, but I really do want to stop and allow questions.
Yeah, let's open it up for some questions or comments, thoughts.
Sarah, hi, my name is Carrie Durbert. I'm from Utah State University and part of the community evaluation partner for this PRC. I am wondering if you could talk a little bit about the time commitment that these types of events ask of your participants, and how they're compensated, how they're given credit for their work, that kind of an aspect.
Yes, it really is an important aspect. Some of the large groups that I did were time consuming. And I did them working with a team. So, but usually it would require a number of months of planning. And it doesn't have to be that intensive during the planning stage, especially if you're experienced. If you're training people, they start to become experienced and they know how to do it. So but the time for participants is considerable, like when you have one-day meetings or travel to get to the group. And so I have always budgeted for that to compensate them with an honorarium and or compensate them with using an hourly rate that they would be accustomed to, and handle it in that way. That's a very good question.
Thank you. That's really helpful. And I was also wondering, Utah is very rural, and there's long distances, sometimes even within our communities. And so I was wondering if these sorts of approaches have been used, if they work virtually. I'm like already
Yes.
imagining all sorts of barriers to some of the quality indicators that you were talking about, but I wanted to hear more about that.
Yes, you can use these approaches virtually. I'm not testing that aspect of in my PCORI grant, if that's funded, but I am doing all the groups virtually, just because that particular consortium had many rural participants, and also many that simply would have a very hard time with travel, even if it's less than 50 miles.
Yeah, as the
Um,
mom of two little kids, I totally get that.
yeah, and
Thank,
it,
go ahead.
yeah, absolutely. One of the things that I think that we have done in some of the work is really pay a lot of attention to childcare, where it's going to be located. Is it near the parents and so forth? Also, doing the groups remotely allows, yeah, for you not to need any special child care. And then you'd build in gaps for those individuals to take breaks that are comfortable for them.
Thanks. That super helpful and really thought-provoking talk overall. Thanks, Sarah.
Thanks, Carrie. That's great.
I
Does
have a
anyone think now they've been in one of these groups before?
question.
Julie, did your block brightened up? Were you going to speak?
I had a question for you. For the Mountain West Prevention Research Center, at least the Building Healthy Families grants. So we have lots of different elements to it. So we have the partnership building RFA, or the pilot project, or sorry, partnership building project. And then we have the pilot project, the Building Healthy Families implementation. And then we have the collaborative. And then we have the working groups within the collaborative. So it sort of goes from smallest to the partnership development to biggest collaborative. Is there a too small of a project to use deliberative democracy?
Well, I think that if you are going to do some engagement, you can use some of the approaches. So if you're using a community advisory board, you can build this in this facilitation style and the structuring into that community advisory board. It actually works. Community advisory boards sometimes work less optimally because there are a lot of experts, they talk, and then people who don't necessarily feel like they have expertise to share don't talk. And usually everyone has been selected because they do have expertise. But this just sets up a framework that's very friendly, that where people get interested in sharing. And you pay attention to it, specifically a lot of like co-creation activities in the small group. I do some of this when I'm teaching, for example. I'll, even if I have a small seminar class, doing co-creation gets everyone starting to talk and sharing their perspectives. And really, when people stop trying to kind of argue the perspectives and kind of understand, just share them and have fun with it, they really start to enjoy it. And that's what we're trying to do in this collaborative deliberation. It's not a debate. It's more of a building from, or like improv comedy, you're, yes, and that kind of approach.
That's great. Okay, Carrie asked, what resources would you suggest to learn how to do this type of facilitation?
I would say find people that have experience doing this. We are training people in the CTSI program here at Utah in our engagement, science, innovation, and translation area. And so we'll be holding training meetings. So that would be one way. We can also do them virtually, so it's easier for people in this group to get there if you would like to do it. The other thing is that you could do readings. And then I have several books I can suggest to you on facilitation and collaborative deliberation. There are a lot of new articles that have come out on collaboration, and those are the ones I would suggest reading and using group exercises and collaborative activities to accomplish these goals. And so I can also, we can provide some of those readings for you and suggest some of the books. I'm hesitant to just say, read all of these because they can be expensive, but there are some really interesting new books on facilitation that address these kinds of questions.
Wonderful. So I just asked a question in the chat. As part of what Caitlin was talking about earlier, the implementation guide, we're building a repository as part of our Mountain West PRC. And so I'm curious if folks would be interested in having a list of resources for deliberative democracy as part of that resource. So if you could just put a yes in the chat, just to sort of gauge who would be interested, I'd appreciate that.
The kinds of things that I'm developing now are training manuals, facilitation guides, quality measures for evaluation. So those kinds of things that, we often would need to do the groups. Some of the other things that I've asked my team to collect over the years are different templates for facilitation guides and other template documents, like how would you recruit people to this? How would you explain it to a community group that you're recruiting? So recruitment messages, consent forms, and audiovisual consent forms.
Excellent. Okay. Okay, so we've got some interest. Awesome. So that is something that we can prioritize for the repository as well.
Great.
Okay. Excellent. Sarah, thank you so much for your time and expertise and sharing that with us. We will be hearing, we'll be engaging with you more. I mean, you're just a critical part of this collaborative and our Mountain West team.
Thank you so much, Julie, and thank you all for listening and for your questions and comments. I appreciate it.